No declarations of interest to make. The reason we conducted the study is that we noticed that on the post-operative X-rays there was a large discrepancy between what we had noticed intraoperatively in terms of the cup placement and how it looked on the X-ray. And we thought what we had noticed is that this tended to occur with the fatter patients. So we set out to determine whether BMI actually influences the acetabular component position. And what we looked at specifically is the abduction angle of the cup. We didn't look into anteversion. That's sort of been established in separate data. Not our data, other people's data. When we do a hip replacement, the aim of the procedure is to relieve pain, but also to restore the anatomy. So in terms of anteversion, abduction, leg length, offset, and soft tissue tension. Lorne's paper from a number of years ago is the study that is most often quoted as the landmark in terms of abduction angles and anteversion. And Lorne has defined safe zones as 40 plus or minus 10 of abduction, and it's those that we've looked to in our study. This study has been reproduced by a small two other authors since then, and they've found differing results. So there's no real consensus, but I think if we took a poll of orthopaedic surgeons, they would tend to agree with those numbers. What Lorne did, I'll just briefly mention because it's important. He looked at 300 hip replacements. There were 9 that had dislocated. They found that within these safe zones, the risk of dislocation was 1.5%, and outside the safe zones, the risk of dislocation is 6.5%, so a significant difference. So a closed cup has a decreased abduction angle. There's a biomechanical study from JBJS in 2006 that found decreased range of motion in closed cups, potentially leading to impingement and polywear. We also know that closed cups tend to have more overhang and may lead to psoas problems, obviously depending on the anteversion. More open cups have an increased abduction angle, and it's well documented there's an increased risk of dislocation with an excessively open cup, and also increased polywear rates in an open cup. So how do we guide cup placement? I would hazard a guess that most of us sitting in this room, knowingly or unknowingly, use alignment guides and the operating table to guide our alignment. So we presume the patient is correctly placed on the table, and then we judge our 45 degrees and our anteversion based on the feedback from the table and the room. There are more formal ways to guide cup placement, and use of bony and soft tissue landmarks are well documented. The use of the TAL has been shown to have a very accurate cup position on post-operative X-rays and a low dislocation rate when the TAL is used. Computer-guided navigation is probably the most accurate when we look at the literature, and there's some studies showing that we can get accurate placement within 4 degrees using computer navigation. Intraoperative fluoroscopy is also described. So what did we do? We looked at 102 hip replacements in Tasmania at the Royal Hobart Hospital over a 16-month period. There were 9 surgeons and 4 registrars passing through in that time. All of the patients were positioned laterally, none of them were positioned supine, and they were all uncemented total hip replacements. We stratified BMI into normal, overweight and obese as per the usual categories, and we included patients regardless of their indication. We did exclude 12 patients, and that's purely because their post-operative X-rays, either on day 1 or day 6, were too rotated and we couldn't accurately assess them. 2 people looked at the X-rays, and we looked at inter and intra-observer reliability, and there's no significant differences there. In terms of radiographic assessment, we used a digital imaging system. We used the ischial tuberosities, inferior pubic rami line, and measured the widest part of the cup and measured an angle based on that. So the angle in that is not at 142, it's 180 minus 142. So our results, there was 90 patients in the final analysis. The range of age was from 36 to 89, and roughly equal numbers of males and females in right and left hips. I'm going to show you 5 tables now. I'll just go through them one by one. This is for BMI categories. I think what's important here is that 82% of the patients were overweight or obese. Maybe that's just Tasmania, but they're very fat. There's only 17% of patients who are normal weight. So we're dealing with a specific population in this study. When we look at the mean abduction angle, as measured on the X-ray and BMI, in the normal weight category, average abduction angle was 36.4, so it's a little bit closed. If most of us are aiming for 40 or 45, it's a little bit closed. And the overweight patients were a bit more open at 42.7. What's important in this slide I've placed in bold, and that is the standard deviation and the range of the obese patients. So it ranged from 28 to 68, which is quite a large range compared to the other groups. When we looked at BMI and mean abduction angles and compared them between normal weight patients and overweight and obese, we found that the difference in abduction angles is statistically significant. We thought that perhaps males and females would show a difference because of the distribution of body fat, but there was no significant difference between the two. We looked at also the approach. Most of the approaches were lateral, 26 posterior approaches. When we look at the lateral approach versus posterior, the lateral approach tended to be more open than the posterior approach, and the difference was significant. When we then look at abduction angle within approach, so for the lateral approach, normal BMI patients tend to have a more closed cup, and obese and overweight were more open, and the same holds true for the posterior, though the values tend to be a little bit more closed for the posterior approach. So those differences within the BMI categories are statistically significant. So what we're seeing there, again, is the same trend that we've seen when looking at the data overall, and it tells us that the approach is probably not confounding the data, it's a true effect. So we've shown that patients with a high BMI tend to have more open cups. Normal weight patients have a trend toward a more closed cup, probably a little bit more closed than we would like. High BMI patients have less accurate placement of their cups, so the range of their cup placement is greater. The lateral approach patients tend to be more open, and that effect is seen more in the obese patients, and the posterior approach tend to be more closed. We thought, why is this? What we hypothesise, and we haven't proven this with X-rays, intraoperative X-rays, what we hypothesise is that in an obese patient, you can see the person sort of laying on the sofa, that the pelvis adducts towards the operative leg, and then when on the post-operative X-rays the pelvic tilt is corrected, the cup ends up more open. And the converse is true for a normal weight patient. We believe the pelvis abducts away from the operative leg, and on the post-operative X-rays the cup is then more closed. And that's possibly because we're guiding our placement, presuming that the patient is placed square on the table. One other study has looked at this. Callanan et al. Looked at 1,800 patients. They found the same thing as us, that BMI leads to cup malposition, both for anteversion and for abduction. However, they didn't specifically comment on the direction of that, in that fat patients have open cups and thinner patients have closed cups. The number of limitations, we haven't followed our patients to actually see if they've had any of the problems that we've hypothesised. It was merely just looking at the post-operative X-rays. And one criticism is that we haven't looked at anteversion. We didn't set out to look at that. It might have been interesting to do so. So in conclusion, overweight and obese patients are unreliably positioned on the operating table, and we should be using local anatomy to guide the placement of the acetabular components in all individuals, whether overweight or obese or normal weight.